I'm Jonathan Cohen. I'm from the Winship Cancer Institute in Atlanta. And really, this is just designed to be a brief introduction to the topic. They'll certainly look forward to answering questions and talking a little bit more about some of the details. So we can go to the first slide. And so the first thing I want to highlight is that, as we've already heard, there are many different ways to treat follicular lymphoma. And so on the left here, this is a type of a plot. It's called a Sankey plot. And I don't want you necessarily to focus on each individual thing, but what I do want to highlight is that this was from a study that we participated in looking at patients who had had recurrent follicular lymphoma and had had up to 3 different types of therapy. And when you look at the different colors and the different lines that are connecting the colors, that is the treatment that patients, each line is an individual patient, and those are the treatments that the patients had at first line, second line, and then third line. And as you can see, there's a lot of colors, and the lines are going every which way. And so as we've already heard, there's no one way to treat follicular lymphoma. And so although we're talking today about bispecific antibodies as one potential therapy, I think it's critically important, as we've already heard, to have a good relationship with your oncologist, to ask questions, and to make sure that the journey that you're on is the right one for you. And specifically, some of the things that we think about for every patient that I see and that I know that my colleagues see is age as well as medical conditions. And the first thing I would say is that for folks, even as they age, they still are almost always eligible for very effective therapies. But our approach may be a little bit different for somebody who is 38 as opposed to somebody who is 78. They may have different goals, they may have different lifestyles and so forth. And so these are all things that are important to take into account. The stage of the disease. So as we've already heard, Ferris, his initial presentation, unfortunately, he had a large burden of disease that required therapy right away, whereas other patients may have a lower burden of disease. And then for those where the disease does come back, we'll look at their prior therapies, how they tolerated them, and then as well as the patient's overall goals and lifestyle. Are they willing to be admitted to the hospital if necessary? Do they not want to have to deal with being in the hospital? Are they okay with being on therapy over a long period of time? Are they looking to do something quickly and move on? So I think there's a lot of different things that we take into account. And then the last thing I would say, at least at our center, is social support. So I practice in Atlanta, Georgia, which is in the northern third of the state. And the lower 2/3 of the state are quite rural. And for many patients, traveling to a place like Atlanta can be very challenging. They may or may not have reliable transportation. Unfortunately, we don't have the trains, the very impressive train system that many of you do in other parts of the world. And so those are all things that we take into account. So we can go to the next slide. So as we look at the next slide, there are there we go. There are several bispecific antibodies that are currently approved in the United States, and one other one, odronextamab, which is also approved in the EU. And just to take a step back, what is a bispecific antibody? So it looks like from the initial poll that many patients on the call have some familiarity or have heard about these. And what these are is this is a form of immunotherapy. And what we see here represented in these figures are the 3, again, approved products in the United States. And these are antibodies. So we all have antibodies in our body that are part of our immune system, but these are engineered antibodies that target 2 different antigens. One is CD20 and the other is CD3. CD20 is a marker that is present on the B cells that make up your lymphoma. And so the idea here is that the antibody is able to identify your lymphoma cells and home to it. And then CD3 is a marker on your T cells. And the idea here is to bring the CD20 expressing cells, your lymphoma cells, in close proximity with your T cells, and facilitate then the destruction of the lymphoma cells by your own immune system, by your T cells. And so really what we're trying to do here is to utilize your own immune system to attack and eliminate the lymphoma. Okay, so there's no chemotherapy in this particular case. This is really using your immune system. And fortunately, what we've seen, there's a number of different studies that many of you may be familiar with or have heard about with these different therapies. They're being investigated in a number of different diseases. But in recurrent follicular lymphoma, over 75% of patients who receive this treatment by itself will have a response, meaning that the overall burden of their disease, the tumors that are visible on scans, will recede, will go down. And these responses can commonly last for over a year. And for those patients that go into what we call a complete remission or complete response, I would say we still don't necessarily know just how long those remissions are going to last. Many of those patients are now a couple of years into therapy and have done, or since starting therapy, and have done quite well. So this is a very exciting new type of therapy. And I would say we're still fairly early on in understanding all of the nuances of of how to use them, whether they should be combined with other therapies, when to use them, and so forth. So we can go on to the next slide. Now, unfortunately, although these are very highly effective, there are a number of side effects that are important for patients and their caregivers to be aware of. Some of you may have heard before of cytokine release syndrome, or CRS. This is all for those of you that are familiar with CAR T therapy. This is also a side effect that we see with CAR T therapy. And this is something that affects upwards of 40 to 50% of patients in some way, usually fairly mild, but it's something that we have to be aware of. And CRS, or cytokine release syndrome, really is where your body thinks that it has a severe infection. Your immune system is being activated, and so you'll have a fever, you may have low blood pressure, you may have a low oxygen level. And for those that are familiar with the term, your body is sort of acting as if you have something called sepsis. So for if somebody wasn't aware that you had a bispecific antibody, they may be concerned that you're developing sepsis. And so this is something that we commonly will counsel patients on, to be on the lookout for. Fortunately, the overwhelming majority of the time, this is of a mild variety. So patients may have a fever, but otherwise be stable. But occasionally it can be more severe. So this is something, again, that we keep a close eye on. And we do have a number of ways to manage it, and it is reversible. Another potential toxicity is neurologic toxicity, or you'll see the abbreviation ICANS. As opposed to what we've seen with CAR T, this is a much less common complication for patients who are receiving the bispecific antibodies, but this can present with some confusion or disorientation. Sometimes it's subtle, so you may, if you're a caregiver for a patient, they may be able to say, "Hello, how are you? My name is so and so." But if you really start to ask them about what's going on, you may pick up some subtle differences. And so an example I commonly give is I have had patients before who were engineers who did math, complicated math for a living, but were in the middle of therapy, and they noted that they were having some difficulty with managing some of their finances because of some math errors. So things like that are a little bit more subtle. And so this is something we like people to keep an eye on. And then I would say the other big side effect that we've come to recognize with this disease, this group of therapies, are infections. These do unfortunately suppress your immune system, and especially a patient who's had other prior therapies in the past. This is something that really does need to be monitored for. Often we'll think about giving medication to prevent infections, but again, if you're on a treatment like this, it's very important that you're aware of that and that you're keeping an eye on infections. And then on the bottom here, you can see a figure from one particular publication looking at different ways that we have adopted to mitigate these safety and tolerability concerns. And so sometimes we'll consider having a patient treated in the hospital. Sometimes, or often, we'll do what's called step-up dosing, where you start on a lower dose and then potentially escalate to the full dose. We often have thought about using pre-medications, often with steroids. So there's a number of things that we have done that have generally resulted in this being a very tolerable approach for a large number of patients. So we can go to the next slide. In addition to some of the toxicities, there are some logistic considerations that I think are really important for patients as well as those that are taking care of their loved ones. And the first is that the highest risk time, the time that is the when we see the majority of the immune toxicities like CRS or ICANS, are in the first few doses, the first few weeks of treatment. And so for that reason, at least in the United States, these are often, not always, but often administered at a large center, often a center that has experience with CAR T and with some of these toxicities. And at times, patients may be observed in the hospital. Usually this is just an overnight 24-hour observation, but again, based on your own specific situation and what's going on with your disease and so forth, you may require longer observation or may not need to be in the hospital. So these are all things that you would want to make sure you talk about with your physician. But our goal ultimately is to be able to transition closer to home. So as I mentioned, we live we practice 3 or 4 hours away from some of where our patients live in South Georgia, and many of them are very excited to be able to move back home once they've gotten through the first initial therapies. However, even once you do return home, it does require some vigilance. So it's important that you're keeping an eye out for fevers, for abnormal behavior or confusion that can develop with neurotoxicity. Again, most of the time, once people get home, the likelihood of this is much lower, but it's still very important to be on the lookout for this. And I think ultimately it's very important to have a conversation with your team about how to manage safely and how to manage these toxicities safely, how to manage the disease safely, and to go over any concerns that you may have. And I tell all of my patients, if something's going on day or night that you're not sure about, don't be afraid to call us, okay? The other thing I would say is that there are usually other good treatment options. And so for whatever reason, if this is not feasible, if you're not able to travel to a large center, if you don't want to have to do that, there are often a number of other good therapy options for follicular lymphoma. And so this is not the only option for most of my patients. Okay, we can move on. So finally, what's coming up? What's on the horizon? So I would say there are two big areas of interest with the bispecific antibodies. One is looking at how best, or whether or not they should be, and how best to combine them with other therapies. Many of you I saw in the chat are already participating in some of these clinical trials. Some of these studies have now been completed and have led to some approvals in combination with chemotherapy, for example. And so there is a lot of excitement about combining with other therapies to hopefully augment or improve the depth of response, meaning to try to get more patients into complete response. And I would encourage you that if you're near a center that offers a trial, to strongly consider participating. This is very promising, but I suspect that when all is said and done, we may be administering these therapies in combination with other treatments. And so I think if there's an opportunity to participate in one of those studies, I would strongly recommend that you consider it. I think there still is more work needed to limit the side effects and to make this easier for patients. We love taking care of patients at our site, but I know for many of them, if they could receive this closer to home and feel comfortable doing so, and their treatment team closer to home would feel more comfortable, I think it would make this easier for many of my patients. And so I think this is certainly ongoing work. And then the last thing, and I think there was also some questions submitted about this, is that there is interest in looking at bispecifics as part of the initial therapy for patients with follicular lymphoma, with diffuse large B-cell lymphoma, and in other scenarios. And for those of you in the U.S. That have a low burden of disease that are not necessarily requiring therapy immediately, I would bring your attention to a large national clinical trial that is currently open at centers all over the country for patients that have, again, what we consider to be a lower burden of disease that are previously untreated. And this is a study looking at using either rituximab, which has been our standard approach in that setting, or using a bispecific antibody. In this particular case, it's mosunetuzumab is what we're using, and trying to see if we can improve outcomes for those patients. And so there is a lot of interest in this worldwide. And again, I would encourage you to continue to subscribe to webinars like this and to keep your eyes on the news, because I think there's a lot more to come.